Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Doctors Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Welcome to the Fuller Butz podcast, a behind-the-scenes look at plastic surgery. We're going to be exploring a different side of plastic surgery today with a very special guest. She's a highly trained super microsurgeon. She trained from Vanderbilt for college, University of Texas, University of Chicago for plastic surgery residency, NYU for microsurgery training, and now you're an associate professor at University of Virginia. Yeah. She's written countless papers, amazing talks, and so much more. And she's actually apologized for her resume being so long. And she's an amazing mother to three very young girls. So thank you, Dr. Amanda Silva, for joining us tonight. That was my best SmartList introduction I could come up with. But yeah, thanks for being here.
Thanks for having me.
So I just wanted to start, for general listeners, microsurgery might be kind of a very foreign term. Mm-hmm. So just tell us a little bit what that is, what inspired you to go there. Did you always want to be a microsurgeon? Yeah,
I did not always want to be a microsurgeon. I didn't honestly even know what it was until I was well over halfway through medical school. And I was trying to decide if I wanted to be a plastic surgeon or a head and neck surgeon. And I worked with one of the attendings who was actually trained in both. And I remember sitting down with him the first time, just talking to him about what I was going to be able to see in the coming weeks, shadowing him. And he showed me this picture of a guy who actually, surprisingly, I was looking back at the paper a couple weeks ago. The guy was 41, which is as old as I am. And he had a liposarcoma resected from his face and prorodectomy, which means taking that gland out. And so it had a huge divot in his face, but they had been able to close him. It wasn't like the skin was too tight. But he looked deformed, and he went to my mentor and said, I don't think I can go home looking like this. My kids are going to be scared of me. And my mentor ended up taking him back to the operating room and did microsurgery to reconstruct him. So microsurgery is taking tissue from one area of the body to the other to fix deformities from cancer or trauma. And when you take a big piece of tissue, you need to take it on a blood supply. And so you need to use a microscope to sew those blood vessels together because they're so small. You can't see them well with your naked eye. And I just remember being so amazed by how he was able to transform that patient and really impact his life. And then the ensuing weeks, just all the stuff I saw was crazy, like taking bones from the leg to reconstruct the face, taking tissue from the abdomen to reconstruct breasts after breast cancer. So I was kind of sold after that and decided I wanted to be a plastic surgeon, but specifically a microsurgeon from that point on.
Those are incredible stories, and really those aha light bulbs were yes, I want. I'm passionate. I'm motivated. I want this to be my calling, and you found that, and that's amazing that you were able to exceed and now become a mentor for other people who are to be microsurgeons or interested in the field as well. I don't think you really highlighted just how challenging or difficult microsurgery is, because you're just hey, we take some bones from the leg and put it on the face. And there's just way more to it than that. Can you enlighten some of our listeners as far as the planning or even just the OR time? How long are some of these cases that you're doing? Because it's pretty intense.
Yeah, lots of planning that goes into it. No matter what you're doing, we usually will get imaging ahead of time to see what are the best blood vessels and where they're at. If we're doing a more complicated reconstruction with bone, a lot of times we'll plan that whole surgery ahead of time to have special cutting jigs to make us faster in the operating room. And the cases are all day. That's why I usually just tell my patients all day. That could be 4 p.m., that could be 10 p.m. Just depends on how complicated it is. And One thing that I also kind of love about microsurgery is it's also very humbling. You can kind of get into a swing where things are going really well for months at a time. All your cases are great and you're really proud of yourself. And then all of a sudden you'll just have this super challenging case and it just kind of brings you back down to ground. And that's kind of, I guess, getting into what's complicated about microsurgery is sometimes the vessels will spasm or they'll clot and you just can't get it working and you have to troubleshoot different ways to fix it. So that's where having a lot of skill and thinking outside the box and different ways to troubleshoot can be really valuable and important in microsurgery.
Yeah, one of my mentors at my fellowship at the Curtis National Hand Center, we were doing like a 4-finger replant, and he after like the third finger, he's like, microsurgery and replantation is really cool and really fun until it's not. Until things start to go wrong, and then you start to have issues, and you start to have to troubleshoot all those things. And so, it definitely is a humbling experience from thinking back on the days of the long, intense cases. Do you have a record case? Like, what's the longest micro case that you've been in?
Interesting. I don't know. I mean, that I've been in, I would say Larry Gottlieb, one of our mentors, legend. He for sure is the longest case I've ever been in, but I honestly don't even know. I just love the cases so much. I don't even pay attention to how long they take. I remember probably the longest case was when I was a resident with him. It was actually after we had gone to our big microsurgery meeting in Hawaii that year. And I remember flying back and I was like really, really pregnant too. I was about to have my first child. But I was like so excited to do this head and neck reconstruction case with Gottlieb. And I think I got in that morning, came to the hospital, did that case. And I'm sure I was there over 24 hours and then finally went home the next day. But it was great because we got to do this really cool case and take care of this patient. And again, just didn't really even realize where the time had gone.
Yeah, mine is a 26-hour Dr. Gottlieb case.
I know exactly how long my longest is.
We were late to clinic the next day, so went straight to clinic all day. And so I think everyone's got. Dan, do you have a number, or do you have a specific one?
It was definitely. I think I was a med student. I did a whole on rotation with Dr. Gottlieb, and it was a 24 5-hour surgery clinic, and then had to take it back pretty quickly afterwards. Yeah. So, I mean, these are like pretty incredible surgeries. And I think some of the advances of, if you look at the success rate, especially for like breast reconstruction, it's like 99.9%, at these high volume locations. Head and neck's a little bit different, but it's just what's wild, like what you can do with microsurgery and how good it's become. Yeah. I mean, some of those big surgeries, Dr. Gottlieb's, famous for his chimeric flaps with you have a bone on one vessel, a piece of muscle, then another bone, and then a paddle of skin, and kind of winding it all together to make a face look like a face. And it's pretty remarkable stuff that most people, like you were even saying in med school, doesn't even really realize it is a field, let alone a field of plastic surgery. So thinking of what advances have like really taken place in the last 10, 15 years. Yeah. Residency is like Vioptics was really cool, or the couplers. People are using robots, and like what is kind of changed? Obviously, I haven't done a free flap in 7 years. Like what has changed? What is new? Is it rapidly getting better, or things kind of getting close to a peak, you think?
I think we're still very much on the uptick. I don't think we're reaching a peak quite yet. Although I don't know. I guess it depends on who you talk to and what they're doing, because it's incredible how much some people are pushing the envelope, like you mentioned, for breast micro recon. People are starting to offer that as an outpatient surgery and being very efficient. And I think one of the areas that has helped us become so efficient is with doing a lot of the legwork ahead of time and preoperative planning. So getting CTAs on patients, picking the best vessel that you're going to go after, knowing the course of that vessel, that all changes. So you don't have to make those decisions, or you don't have those uncertainties in the OR, and you can be more definitive, and it makes the surgery faster and more reliable. So that's something I think has been a huge advance, although I wouldn't say it's like this cool future thing. It's, but when we were residents, we didn't use preoperative imaging. And that's something that I feel like as an attending, I've really learned how to use as a tool to make myself more efficient. I would say that also imaging in general for other areas. So I think we're going to talk about this probably. So I guess not to be a spoiler, but lymphatic surgery. There's a lot of advances that we're able to make in lymphatic surgery with doing intraoperative imaging and using ultrasound to help pick better lymph vessels for surgery. For robots, I'm not sold yet, but maybe that's a little bit of the future for some of the microsurgical options. People talk about doing it for deeps. You get to reduce the donor site morbidity quite a bit with that. It's smaller fascial incision, so there aren't as big, not as much collateral damage to the abdominal wall, and maybe more steady hands for like the really, really small microsurgical anastomoses using the robot. So I think that it's not ready for prime time, but that could be an area in the future for sure.
Let's talk about some of the great points that you brought up. You had mentioned that just the definition of microsurgery, you're taking tissue, large quantities of tissue from one part of the body to the other. And then in order for that to survive, you have to reconnect the artery, the vein, so there's inflow, outflow. And that's what the difference is between a graft where the tissues are still living and it's really reliant on the recipient bed to grow in, to have new blood vessels, angiogenesis form. Take our listeners through like what that ischemia time is like. You're disconnecting an artery and vein, and then you have to, quote unquote, hook it up. Maybe just, take us, what that's like. Are you, as far as using a microscope, what magnification that is, and then, how thin are the sutures are that we're talking about as far as reconnecting arteries and veins, because it's a pretty cool, very humbling, but also very empowering experience when you're almost like Frankenstein, like making things alive again. So, take us through that intraoperative situation where you're hooking blood vessels back up to a flap.
Yeah. So the blood vessels we're hooking up are pretty small. Depends on what kind of reconstruction you're doing, but anywhere from about sub 1 millimeter to as big as 3 millimeters. The ischemia times, that's once you cut the blood vessels and that tissue that big piece of tissue that you're using for reconstruction doesn't have blood flow. And the tissue can only go a certain time period without having blood flow before it starts to have cell death, and you're going to have issues with necrosis in the flap, even once you hook it back up to a blood supply. Different tissue types have different ischemia tolerances, but around 6 hours is kind of like a generic time that people talk about. But usually you're not getting into a situation where you have your ischemia times that long. Usually the ischemia time is anywhere from, it can be as short as 30 minutes if you're super facile, or it can be more like an hour to 2 hours if you're doing a jaw reconstruction and you kind of inset everything and get everything kind of built before you finally hook up the blood vessels. So it all kind of varies. But as far as hooking up the blood vessels, because they are so small, we have to use something to augment our vision. We can't just do it with the naked eye. You can do a microscope, which I like. I think that you get really nice, clear vision. You're able to teach, I think, a little bit better when you use the microscope. And you can get very high magnification, like 40 magnification with a microscope. You can also just use loops, which are these fancy glasses that have telescopes on them. We use those when we're raising the flaps to be able to see, and those can be anywhere from as low as 2 magnification to 4.5. I have 4.5s that I wear. And what's nice about once you start to get above like the 3.5, you can even sew the blood vessels together with just your loops. And so that's where, like, when we talk about efficiency, that's where sometimes the loop micro is an advantage, because you aren't bringing in a big microscope. And so you can be a little bit more mobile, especially if you're working with another microsurgeon, you're doing bilateral breast reconstruction. One person can be doing the anastomosis with just loops on, and they don't have this big bulky microscope in the way, so the other surgeon can be still working on moving the surgery along.
Sam does liposuction with his loops on, his 3.5 loops. Super,
Well,
super
yeah,
high definition.
I have a feeling that Larry Gottlieb's going to be brought up a lot in this podcast, but yeah, I remember he would wear them for burn cases, and I questioned it once, and he looked at me like I was crazy, and like, why wouldn't you wear them?
He looked at you through the loops, yeah.
Over the loops.
We were all trained by the same guy. He wore them in the office too, and I was in on a burn case, and he was able to say which microvessels were clotted and which weren't for viability. So I feel very unarmed without the loops, and so I do wear them for lots of cases. So getting back to microsurgery, sutures can be thinner than human hair that you're putting together. One of the more novel approaches when we were in residency was the coupler, the venous coupler, or being able to coapt or bring vessels together without the need for suture. Is there any advances for the artery? Are you coupling arteries? Are you still hand sewing? Is there any kind of latest and greatest techniques to make that less likely to fail, to leak, to clot?
Not personally. Not really. Some people do talk about coupling the artery, but I find it once you start to get really facile at sewing the artery, it's not that much faster to couple it, and it is pretty reliable. It's very rare that you have issues with arterial clot, especially in breast reconstruction, deep reconstructions. So usually just stick into the good old sewing it with some suture. That's the size of your hair.
And maybe we can switch into lymphatic surgery since you brought it up as well. So lymphatic, I think, is a misunderstood, or at least a lesser known, way of microsurgery application, where I have patients routinely come in with lymphedema, and I kind of point it out to them and ask them, have you tried getting that treated? And many a time they say, oh, there's no treatment for it, I just have to live with it, or I just have to wear a sleeve or something. And so I still think it's not out there that lymphatic surgery specifically for lymphedema, swelling of the lymphatics, is a possibility and something that's becoming more and more mainstream. And this is just me as somebody who does not perform it, but as we all were taught under Dr. David Chang and other lymphatic surgeons. Maybe Amanda, you can take us through lymphatic surgery and some of the nuances, or just the preparation and just the results. So what can you expect for treatment for lymphedema?
Yeah. So lymphedema can be a very vast topic. And so to kind of keep it simple, the majority of people who have lymphedema in the United States and the developed world have it from cancer. And that's from, if you have to have surgery in your lymphatic basin, most common breast cancer, women who have surgery in their axilla, that can disrupt the lymphatic flow of the arm. And so then you get swelling of the arm. Also, things like radiation, chemotherapy can contribute to the risk of developing lymphedema. And as you mentioned, traditionally, it's always just been, you just kind of manage it with massage, with compression. It's something you just kind of live with. But with super microsurgery, so taking the magnification and the resolution of the scope even higher, we can...
How high?
around 40 meg. You can see these tiny lymphatics, which are the size of your hair. They're sub-millimeter. And what you can do is there are kind of two different ways to treat lymphedema. You can do what they call debulking surgeries, or you can do physiological surgeries. The debulking surgeries are like liposuction, cutting off the extra mass of tissue on the arm, but those aren't going to treat the underlying lymphedema. Those are symptom control things, and they can be very helpful for patients, but the patient's still going to have to wear compression and do massage, and that's not going to treat the underlying disease. Things that can treat the underlying disease are doing things like lymphovenous bypass or vascularized lymph node transfers. Lymphovenous bypass is where we use a special camera. We inject a dye into your web spaces of your digits of the affected extremity. And then we can use a special camera to visualize the lymphatics and see where they're flowing normal. And then they're hitting areas where they're hitting scar and they're not flowing properly. And then we make little cuts about an inch long to find those lymphatics. And then we find veins that are nearby, and we cut the lymphatics and we sew them to the nearby veins using the microscope. So we're sewing a lymphatic that's usually about a millimeter, less than a millimeter in size, to a vein that's also very small, about 1 to 2 millimeters. And that allows the lymphatic system to decompress through that vein, because eventually lymphatics flow into your vein system. It's just at a higher level up in your neck. But this is a way to kind of bypass where it's been scarred and it can't flow anymore. So that's a nice option, especially for people who have earlier lymphedema. Their arm isn't as swollen. It's just, you still what we call, say, have pitting. When you push on the arm, the tissue is soft. That tends to be a nice option for those patients. And patients who have lymphedema due to breast cancer, so a known reason for lymphedema, and it's in their arm, that tends to be a good option for them that they actually have good results from. The other option is to do a vascularized lymph node transfer. That's where you're going to take lymph nodes somewhere on your body where they're extra, and then you move them to the arm that has the lymphedema. And you can put it anywhere along the arm. There's different debates on the pros and cons of where you put it. But the idea with that is you are hooking up the blood vessels, the artery and the veins, to have good flow into those lymph nodes. And then they kind of find a home in that extremity, and they build lymphatics, and they start to function as a new lymph node basin for that extremity, and they pump the lymph fluid out of that arm. And that tends to be a better option for patients who have lymphedema that's a little bit further along, a little more progressed. That was my long-winded answer to lymphatic surgery for you guys.
That's great. I mean, I remember when Dr. Chang first came to University of Chicago and he started doing lymphatic surgery, and it was like, it's just this whole, system that we often kind of just overlooked, and all of a sudden you're seeing it. And like, this normally is just this kind of invisible to the naked eye, very important, bodily system. And kind of making it work better. It's just wild, like what you could do. Again, 40 loop magnification, not loop, under a microscope, and pretty. The actual procedure themselves are pretty straightforward. In and out, pretty dramatic improvements for patients. Yeah. And now that can help me appreciate when people start talking about doing lymphatic massage for liposuction, like how that can those can get bogged down, and it can help things get that fluid moving around. It's just pretty cool developing field still.
Mm-hmm. Yeah,
and it's for functional gain. It's not a cosmetic, like, oh, I don't like that my arm's a little bit full. I mean, patients are dealing with pain. They're dealing with all of the symptoms that come along with that. So there's a lot of functional gain for that. Amanda, if we're taking lymph nodes from another part of the body, like say from the groin, and putting it into the armpit to help with an arm lymphedema, is there a risk that we can cause lymphedema from the surgery in the leg? There's a question that I know patients and listeners are probably thinking.
Yeah, I think there's always a theoretical risk, but there's kind of a tenet in plastic surgery that you never. I'm gonna butcher this, but you guys know this, where essentially, I'm not going to even try to say the saying, but you don't want to take anything from something on the body that would. Thank you. I always say it, and then I think it doesn't sound right. But only if robbing from Peter to pay Paul, but only if Peter can afford it. I feel like it was only if Paul can afford it, but that doesn't make sense, right? I don't know.
Oh, I didn't know it had to do with what their bank account was like.
Yeah, right.
Well, you're always stealing from something.
Peter to pay Paul, but only if Peter can afford it.
Yes. Right? I get it.
Yeah. That's people always say only Paul can afford it, but that doesn't make sense. I don't know. Maybe I'm just remembering it wrong. But so essentially, you don't want to take lymph nodes from somewhere where where you have a high chance of causing lymphedema. And there are measures that we can do to make sure that we're not going to. So you can reverse map. So you mentioned taking it from the groin. That's a common area we take it, especially if a woman hasn't had breast reconstruction and desires it. You can do a deep flap, so taking the tissue from the abdomen, and you can take the superficial groin lymph nodes that are along the abdominal wall and restore them to the axilla. You are leaving the deep inguinal lymph nodes, which are the ones that drain the leg, and then you also can do reverse mapping of the leg, where you put in some sort of tracer in the leg and identify the lymphatics and the lymph nodes that are draining the leg, and you leave them alone. So a lot of times when you're putting in some sort of dye or tracer to identify lymph nodes. You're doing it so you can purposely take those nodes, but this is the opposite concept where you actually identify them so you leave them alone so you aren't disrupting the lymphatic flow to the leg.
Well, as you were giving me flashbacks to the lymphatic surgery rotation I had with Dr. Chang, I remembered both the humbling nature of this super microsurgery and also another saying where I felt confident as a chief resident doing microsurgery. And then the first time under that 40 times magnification, trying to use 11-0 suture to, sew these lymphatic things that I didn't even know existed in the wrist. And now I'm trying to sew them together. And I'm looking at myself like shake, tremble under the 40x magnification. And Dr. Chang just casually said, "Oh, Sam, do you want some fries with that shake?" Which I don't think that helped me, but it helped lighten the mood. And I think that kind of maybe jumps to some other questions. Dan, do you want to jump into next set of questions we have for Amanda?
Yeah. I don't know why. Sometimes when I'm at the end of a grueling 3.5 hour mommy makeover surgery, I'm like to start thinking mainly when my oldest is 10, what would my 10-year-old self be thinking about what I'm doing right now? Do you ever think about looking back on long training history, where you started, where you become, is this where you thought you would be? What would you tell them? I don't know, just kind of a reflective question.
Yeah. As far as if this is where I thought I would be, obviously, microsurgery I didn't even know it existed. But I would say from a very young age, I knew I wanted to be a doctor. My dad was a doctor, and I remember being 4 years old and sitting in the basement with him, and he would be reading, he would be looking at echoes on this old projector, and I would just sit there in the dark with him, and I was just amazed at the body. And so I knew, and I just idolized him. So I knew I wanted to be a doctor. And I always knew I wanted to be a mom. I just always wanted to have lots of kids. And so my 10-year-old self would be very happy and proud of the straight trajectory to what I wanted to be. But it was interesting when I read this question, when you guys sent it to me, telling my 10-year-old self all this stuff, my 10-year-old self would be like, "Oh, awesome. Great." I think my 10-year-old self hadn't faced the challenges yet that my 20-year-old self was facing. And so I feel like there might be more value in being able to talk to my 20-year-old self and kind of giving my 20-year-old self a little bit of a pep talk and, keep your eye on the prize, that life is not linear, that there are going to be all these pathways that you don't expect, but there's always kind of a purpose behind that. And that if you have the drive and the determination and it truly is what you're meant to do, it'll work itself out.
Yeah, it's a long road. I mean, any plastic surgery training, probably really any surgical specialty, it can, those 6, 7, 8 years of residency training fellowships. I mean, it can get grueling. So you really you need to love it and be passionate about it to make it worth all that effort. But if you have the right mindset, the right goals, the right reasons to do it, then it's typically worth it.
Well, now we're asking apparently the 41-year-old Amanda Silva some questions. So we're asking you now, how do you do it? How do you balance it? So as you were talking, I just clicked refresh on our podcast. We're being listened to in 23 different countries. I'm sure there are some prospective medical students, residents who are, chiming in, being motivated to hear about you. You're a mother of 3 daughters, all under 10. You have a robust microsurgery practice. You're in academics, you're teaching, you're attending meetings. How do you balance it all? What are the tips and tricks to become as successful as you are? Yeah. Sorry to drop your age. That's how I want to.
I still feel like I'm 16, so it's fine. I think a lot of help and support. I think I'm incredibly, incredibly lucky and would not be able to do anything that I do without my mother-in-law. When I was pregnant with my first daughter, Caroline, when I was a chief resident, my mother-in-law sold her house in Memphis. She had the house that my husband had grown up in. She sold everything, and moved into a 2-bedroom apartment with us in Chicago, and has raised my kids ever since, and has been just like a stable presence for them. And anytime, like, I never have to worry about if I get called in the middle of the night, or if I need to go to a conference. I know she'll always reliably be there taking care of my kids and doing a great job. So that's like first and foremost, I think, how I'm able to do it. But I think also like that I really do love what I do. I think that if I didn't have that passion, that it would be a lot easier to decide to go somewhere where I work less hours, where I don't have to do kind of these off hours things, like journal clubs on weeknight evenings, or going to conferences on the weekends. But it's truly what I love doing. So that sacrifice is okay. I think as my kids get older and start to realize I'm not around as much, that has been a new challenge, and trying to just like really prioritize them too, and being okay like doing that. So either blocking out time in my schedule to make sure I make it to my daughters. Like, they're doing some music show and tell thing next week. And so I just said, okay, I'm just going to do a half day of clinic next week, and I'll be off in the afternoon so that I can make sure I can be there at 2:30 to see her sing and dance in her second grade classroom, and it's, you say that and it sounds like silly, but it's really easy for me to do that. But seeing the look on their face when you're there, they're so proud and so happy that you took the effort and the time to come and be with them, is like, it like melts you. It's great. So I think, those are kind of the big things, having the support, and then also like prioritizing the people around you, and kind of looking at things from a bigger perspective, and not it's easy to kind of get tunnel vision and focus on yourself. And I think trying to kind of sit back and look at other people's perspectives too.
For sure. Yeah. Real words, well-spoken. I came to this realization that, being a dad, we all have 3 kids. So like, it's juggling, we're outnumbered. But, treating, parenting is the same way. If you want to be a great microsurgeon, you got to train, you got to practice, you got to put the time in. Same thing with parenting. You got to, you have to put the time in, and then it's just as rewarding, just as satisfying, just like, you had mentioned. We're going to shift gears here. I'm going to do a couple of rapid fire questions for you. So okay. Just want, just kind of quick answers, just to kind of get things rolling. So, what would be your favorite free flap or microsurgery procedure? What's your favorite?
My favorite is the esoteric cases where I never do the same thing again. I just love like thinking through the process and like fixing a problem. This isn't rapid fire, name it.
What body part do you move to another body part?
Wait, what? Huh? What?
What if you, whether it's esoteric, like, is there a specific one where if you have it lined up for next week, you're like, oh man, I love that case?
I love head and neck reconstruction. And so usually, if I can do like a chimeric fibula, I love it.
Would you rather be in the office or in the OR?
In the OR.
Or no, I don't know. These are rapid fire questions. You already answered. So, what
you've done?
What is your favorite surgical instrument? Like, what is the one thing you dissect with, you use all the time, you have to have? It's your baby, it's your child. You gotta have it with you at all times.
Can I give 2 answers?
Sure.
So the McCabe, for sure, a McCabe. But I'm really guilty of just using my fingers to operate and dissect.
Interesting. What is your favorite resource to learn about microsurgery, about plastic surgery? What's your go-to?
Nowadays I usually go to PubMed and find articles and read articles. I feel like that's my best way, but then also talking to colleagues, that's super helpful. Like if I have a complicated case, I'll just text people that are my level. So it's kind of, I feel like there's a little bit less filter, and they'll just kind of, it's just a little less pressure than like reaching out to your mentor about a tough case, or a case that maybe isn't worthy of reaching out to them for. So yeah, my peers
Great.
is probably
Okay.
my
And then who was your favorite senior resident at University of Chicago?
I plead the fifth.
All of those rapid fire questions was just to get you to answer that question.
Yeah. Failed. What else? So those are great questions from Sam. He normally likes to pack them all in one and then make you answer them all. So that was good to get the answers out. Yeah. So I guess you work with a lot of residents now. For anyone who might be kind of interested in plastic surgery, what are there like key things that you're like, you got to do this stuff to get into it, or it's just find someone, a mentee, and try to work through them, or what would you say is the route to getting into plastic surgery these days?
Yeah. It's tough, but I feel like the kind of the common theme that's always been the theme is plastic surgery is a small world. And I feel like you really need to be part of that plastic surgery community and supported to successfully match and develop your career. So I would say that if you are fortunate enough to be somewhere that has a home program, like hang out with them, go to their conferences, go to their journal clubs, learn about plastic surgery, shadow them, just to kind of, it'll be good because you'll learn about plastic surgery, but then you'll also become more of a known entity and part of their community. If you unfortunately don't have a home program, seek out mentorship at other programs that are nearby early on. There are also many other great resources through ACEPS, the Academic Council of Educator Plastic Surgeons. They recently changed the name from ACAPS to ACEPS. But they have a lot of great mentorship programs as well, where you can virtually be partnered with someone who can help you navigate not being at a program that has a home institution, or being at an institution that has a home program.
Yeah, I think that was commonly like, you kind of just got to be around. So, people aren't going to go out, especially, they're busy. Plastic surgeons aren't going to be like, oh, do you want to come, do this? So you have to kind of just be there, go to the meetings, go to the conferences, try to, not ask just one question, but multiple times. You become a known entity, and obviously you don't want to be annoying about it. There's that careful balance, right? Of like being present and engaged, but not like stepping on people's toes.
Right.
But it's so true. Like, you gotta, just find the right person who will kind of take you under the wing, and then, expand from that.
Yeah. You miss 100% of the shots you don't take. And so you don't know what's out there unless you take a reach. And so, when I was a first year medical student, I somewhat by chance purchased for faculty auction an orthopedic surgeon, a plastic surgeon, just for fun, just because it was part of this mission trip I was going to the Dominican Republic for, to help sponsor them, but then met the chief of plastic surgery, Dr. David Song at the University of Chicago, who really wowed me over dinner about what plastic surgery is, talking a lot of, similar to what Amanda said about how amazing, how incredible this is, and totally put it on my radar from not even knowing what plastic surgery was, or really relying on TV, social media at that time to, try to consider what that was, and to the reality of how amazing and life-changing plastic surgery can be for people. So, I second that. You just, put some feelers out there, try it, go, ask to do a one-day, shadowing experience. I'm, seeing some college students and high school students kind of come see me in the OR. And I think that's the way to go. And, Amanda's now way up on the mentoring scale within plastic surgery. And so, maybe we can leave a link for your webpage or your, Instagram and stuff, and have patients or prospective mentees or individuals who are interested reach out to you directly, because I think you would be an excellent resource for that.
Yeah, I'd be happy to. Yeah, so a medical student messaged me on LinkedIn the other month, and I mean, I'll respond. It's hard to find the time. We are busy, and so I would also say if someone doesn't answer your email, don't take it personally. Just email them again. You probably got lost in their mountain of emails. So, yeah.
One last question, then we should probably wrap it up because it's getting late. We all went to University of Chicago for residency. We probably share, like we mentioned, a lot of, similar learning kind of anecdotes and stories from, the same kind of mentors. And do you have a specific kind of moment from residency that you kind of reflect on routinely, whether it's during one of those long cases or preparing for it? Mm-hmm. Any funny ones you want to mention about Dr. Fuller being crabby or something? You know, Snickers.
That was so chill.
I'm going to say two things. So one is I remember the first time that I was under the scope doing, it was a nerve repair with Larry Zachary. I think I was a PGY2, and I was horrible, so horrible. And it took so long, and he was so patient. He never said a snarky comment. There was some sighing, but he sat back, he let me do it. And when I finally finished it and it was like the end of the case, and I went over to him, I said, thank you for being so patient. He's like, oh my God, I know. It was awful. But he knew to not like pressure me at the time and kind of give me my space to learn. And so a lot of times I find myself with junior residents kind of channeling Larry Zachary's patience, which you guys, trained with him too. He's a hilarious man, but it has many sides to him, but had a lot of patience to him. And so that's something I really, really always valued and try to do with my residents as well. And then I would say the other thing that I remember really fondly from residency that I always try to reinstill everywhere I'm at is I think we just had like a really fun community. Like our resident roast that we did at the end of the year was always something that I really looked forward to. It was so fun. I have our old videos, and sometimes like if having a bad day, I will go back and watch those old videos, and they will make me laugh so hard. And I've found that not all programs have roasts, because usually there's some story that someone got, offended and they stopped doing it. But I think that when you can be in a group where you guys can laugh at each other, that's just like such a great environment to learn in, because you all kind of can trust each other and not take each other too seriously. And I just think it's a sign of being in a really good, supportive place. So.
Yeah, culture is huge. Where you train and trying to find the right medical school, the right residency, the right fellowship, and then ultimately the right job. You've now transitioned over to University of Virginia, have been there for about a year, or coming up on a year soon. Have you found any self-care remedies for stress, for overall health in Charlottesville? Because that's one thing that I feel like as doctors is we sort of neglect is, if you're going to be under the scope or under, your loops for 8 hours, 12 hours, 16 hours, that takes a toll on your back, your neck, your overall mental and physical, stressors. Do you have any secret tips for us for, how do you yoga? Do you stretch? Do you, is there a protein supplement? Like, how are you staying so fresh all the time? What's the secret?
How are you still
I'm
15
exhausted today.
Yeah. So
don't
I
wear loose during lipo. Like, what's the secret?
Another figure deck.
So Charlottesville is beautiful, and I love just being outdoors and going for walks. And that's actually another way that I kind of tie in my family. So like if I notice that one of my daughters is kind of acting out, it's usually because they aren't getting enough attention. And so I'll offer to, when I get home from work, to go on a walk with just them. And that's nice because we're out in nature, and then it also gives us the time to talk, and it gets them like one-on-one attention with me. So I do that a lot. I would like to say that so this is very timely because I was just recently thinking about how I don't do enough self-care and like have a plan where I'm going to start doing morning and PM yoga, and I'm going to try to row on our rowing machine that's just kind of sits there and doesn't get used at least once a week. And I think I've done morning yoga one time this week. So I don't know. Talk to me in a couple of months and see if I've gotten to my goal. Sometimes I'm just guilty of, after a long day, sitting on the couch and watching bad TV. So
I mean,
sometimes I try to convince myself that operating is really physically demanding, and that counts as working out, but it doesn't.
You got to relax and just let your brain just rest as well. So it can't always be full go. But this was an amazing episode. Thank you so much, Dr. Amanda Silva from University of Virginia, super microsurgeon extraordinaire. We knew during residency you were going to be a star, and obviously you are. As everyone who listened to the podcast, can see, Amanda's well-spoken, extremely educated, and is, giving lectures, giving talks, mentoring, educating, doing research, providing direct patient care, doing those one-off, crazy surgeries that no one else can do, whether it's in irradiated tissue, head and neck, very complex stuff, and she has a real passion for it. And so we feel very privileged to be a part of your training, to be part of that positive culture that you reflect on, as far as having some laughs and some poking fun at each other. And we continue to do that through our podcast and with each other. So if you ever have a hard hand case, hopefully I'm on your speed dial for that, for those options. But thank you so much for being here. Any last comments, you guys?
Thank you for having me. And I will say that I was tickled when I saw that you guys started this podcast. Your banter is incredible. I love that you have this outlet, and I love that it's called Fuller Butz, because I think we used to joke about you guys going into practice together and having a practice Fuller Butz.
Yeah, that was the goal. This is all we could reach to, was the podcast. Awesome. Thank you, man. A great chatting as always. Hopefully we'll see you at a meeting again someday.
Yeah, definitely. Good night.
Night.
All right. Good night.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButzMD. That's Butz with a Z, for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.